Hello everyone, welcome back to our channel. Today we're diving into part 2 of our series on cardiomyopathy, focusing on surgical management. In this part, we will talk about LVOT surgery and heart transplantation. Let's get started. So when heart failure progresses and medical treatment is no longer effective, surgical intervention including heart transplantation is considered. However, because of the limited number of organ donors, many patients die waiting for transplantation. In some cases, a VAD or ventricular assistance device is implanted to support the failing heart until a suitable donor heart becomes available. Let's talk about left ventricular outflow tract surgery. When patients with HCM and LVOT obstruction become symptomatic despite optimal medical therapy or cannot tolerate medical therapy, surgery is considered. The most common procedure done is a myectomy, sometimes referred to as a myotomy or the Morrow procedure. Possible complications of this procedure include complete heart block and subsequent pacemaker dependentness, ventricular septal defects, or failure to adequately elevate the obstruction. Surgical mortality rates are reportedly between less than 1% and as high as 16%. Moving on to heart transplantation. Because of advances in surgical techniques and immunosuppressive heart therapies, heart transplantation is now a therapeutic option for patients with end-stage heart disease. Drugs like cyclosporine and tacrolimus are some of the more common immunosuppressants that decrease the body's rejection of foreign proteins, such as transplanted organs. Unfortunately, these drugs also decrease the body's ability to resist infections and increase the risk of various cancers. And for that, a satisfactory balance must be achieved between suppressing rejection and avoiding infection. Cardiomyopathy, ischemic heart disease, valvular disease, rejection of previously transplanted hearts, and congenital heart disease are the most common indications for transplantation. Typical candidates have severe symptoms uncontrolled by medical therapy, no other surgical options, and a prognosis of less than 1 to 2 years to live. A multidisciplinary team screens the candidate before recommending the transplantation procedure. The person's age, pulmonary status, other chronic health conditions, psychological status, family support, infections, history of other transplantations, adherence to therapeutic regimens, and current health status are considered. Some patients are candidates for more than one organ transplant, such as heart lung, heart kidney, or heart liver. Orthotopic transplantation is the most common surgical procedure for cardiac transplantation. Some surgeons prefer to remove the recipient's heart but leave a portion of the recipient's atria with the vena cava and pulmonary veins in place. This is known as the bilateral technique. However, this technique has been modified to a more common approach called the bicaval technique. This technique includes the removal of the recipient's heart and the implantation of the donor heart with intact atria at the vena cava and pulmonary veins. This newer approach is associated with decreased AV valve regurgitation, arrhythmias, and conduction abnormalities. Patients who have had heart transplantations are constantly balancing the risk of rejection with the risk of infection and disease, such as cancer. They must adhere to a complex regimen of diet, medications, activity, follow-up laboratory studies, biopsies of the transplanted heart to diagnose rejection, and clinic visits. There are 3 classes of medications that are prescribed for a transplant patient to help minimize rejection, like corticosteroids such as prednisone, calcineurin inhibitors like tacrolimus and cyclosporine, and antiproliferative agents like mycophenolate, mofetil, azathioprine, or sirolimus. The transplanted heart has no nerve connections, meaning it's a denervated heart to the recipient's body, so the sympathetic and vagus nerves do not affect the transplanted heart. The resting rate of the transplanted heart is approximately 90 to 110 bpm, but it increases gradually if catecholamines are in the circulation. Patients must gradually increase and decrease their exercise, meaning extend the warm-up and cool-down periods, because 20 to 30 minutes may be required to achieve the desired heart rate. Atropine does not increase the heart rate of transplanted hearts, and digoxin does not decrease the heart rate in atrial fibrillation. Additionally, many patients who have had heart transplantations do not experience angina with ischemia and may present with congestive heart failure, silent myocardial infarction, or sudden death without a prior history of coronary artery disease. In addition to rejection and infection, complications may include accelerated atherosclerosis of the coronary arteries, known as cardiac allograft vasculopathy, accelerated graft atherosclerosis, or transplant coronary artery disease. Both immunologic and non-immunologic factors cause arterial injury and inflammation of the coronary arteries. The arterial smooth muscle proliferatives, and there is a hyperplasia of the coronary artery intima, accelerating atherosclerosis along the entire length of the coronary arteries. Hypertension may occur in patients taking cyclosporine or tacrolimus, due to the effect these medications have on the kidneys. Osteoporosis is a frequent side effect of the anti-rejection medications, as well as pre-transplantation dietary insufficiency and medications. Patients with a long-term sedentary lifestyle are at greater risk for osteoporosis. Post-transplantation lymphoproliferative disease and cancer of the skin and lips are the most common malignancies after transplantation, possibly caused by immunosuppression. Weight gain, obesity, diabetes, dyslipidemias, hypertension, and kidney failure, as well as central nervous system, respiratory, and gastrointestinal disturbances may be adverse effects of corticosteroids or other immunosuppressants. Toxicity from immunosuppressant medications may occur as well. In the first year after transplantation, patients respond to the psychosocial stresses imposed by organ transplant in various ways. Most report a higher quality of life and can return to activities of daily living and to work with little to no functional limitations. Some have significant feelings of indebtedness to the donor or experience guilt that someone had to die for them to be able to live, which can negatively affect their adherence to the medical regimen. That's a wrap on part 2 of cardiomyopathy, including surgical management like LVOT surgery and heart transplantation. In the next part, we will continue this surgical topic, talking about mechanical assist devices and total artificial hearts. If you found this information helpful, don't forget to like, share, and subscribe to our channel, and stay healthy, stay informed.